So glad you're back home.
Me too.
You know, numerous studies have demonstrated that the healthcare field needs to pay more attention to the transition of care process for patients. Seeing the confused look on patients' faces when they try to read a poorly designed discharge instruction sheet will tell you the same thing. Fortunately, this situation is starting to change for the better. Several initiatives, along with hospitals and physicians themselves, are developing strategies to improve transitions of care. But what should these changes look like? Well, while they may not be able to tell you in technical terms, your patients know what they need.
What I'd like to see is, what do you call it? Well, I don't know what the name is, but someone who is on your side, someone who can really help you when you're being let out of the hospital.
There can be a lot of complications with diabetes. So when they let me out the hospital, I wanted all the information I could get my hands on. Frankly, I wanted to be more the one in charge.
It's not that we didn't get information when we left the hospital, but a lot of it was pretty technical stuff.
Yeah, what I really wanted to know is when I could shovel the snow again.
The hospital that I liked the best, and we've been to a lot of them, we had a nurse. He was designated as our go-to guy. One guy. He kept the schedule, he answered all our questions, and when my wife got out of the hospital, he was the one who told us what to do at home. We had a nice relationship with him.
Understanding your patient's needs, helping patients and families successfully navigate through multiple care settings, and ultimately getting them back home whenever possible has never been more essential for healthcare providers. And because this work is so important, this program will examine several new approaches to discharge redesign. Please note that a viewer's resource guide containing resources such as sample forms and materials accompanies this program. The good news surrounding transitions of care is that a variety of new, innovative, and effective approaches to discharge redesign have been emerging throughout the recent past. One organization that has been instrumental in furthering the dialogue on transitions of care is the National Transitions of Care Coalition. The NTOCC was formed in 2006. It has over 30 participating associations and organizations that are addressing the critical issues surrounding transitions of care. One of the primary goals of the NTOCC is to break down the silos and barriers between different healthcare settings and help them work more collaboratively for the good of the patient. To this end, the NTOCC provides information and tools to caregivers, healthcare professionals, policymakers, and patients to better understand and improve transitions of care challenges. One of NTOCC's member organizations is the Society of Hospital Medicine. With funding from the John A. Hartford Foundation, SHM has begun a project to improve the movement of patients from the hospital setting to back home. This initiative is known as Project Boost, Better Outcomes for Older Adults Through Safe Transitions. Leading the effort is Dr. Mark Williams.
The hospital discharge is an ideal instance where quality improvement principles can be applied to improve hospital care delivery. And with Project Boost, we first developed a toolkit that had all the materials that a hospital needed to improve their hospital discharge process. But we didn't want to just create tools to improve the hospital discharge process. We recognized that we needed to figure out how best to implement these tools in the hospitals at which we were rolling out this toolkit. And so we included in the Project Boost toolkit not only materials around the discharge process, but also materials related to quality improvement. How to set up your team, how to run a meeting, how to create a flow map of what's happening with the discharge process in your hospital, And then what interventions should you undertake initially and alter that flow map to deliver better care to patients?
It's important to note that Project Boost is much more interactive than simply distributing a toolkit. They also use a process called mentored implementation.
We partner hospitals with an expert in quality improvement and care transitions who's a physician who's dealt with this at their own institutions or with other hospitals. And so these mentors contact the hospital and the quality improvement team. They have regular conference calls. They commonly perform a site visit where they'll visit the institution.
Another important aspect of the Project Boost approach is a rundown of what they call the 8 Ps. These represent patient issues that healthcare providers should take special note of because they indicate a potentially higher risk for hospital readmission. The 8 Ps include prior hospitalization, problem medications, psychological issues, principal diagnosis such as heart failure or COPD, polypharmacy, poor health literacy, patient support, specifically the lack of it, and palliative care and symptom management. In addition, Project Boost strongly advocates a teach-back approach to patient education.
You check with the patient to make sure they truly understand what's wrong with them, what they're supposed to do to help themselves and treat themselves by having the patient teach back to you, the healthcare provider, what they're supposed to do. And this is a good way to check the patient's understanding and also then allow patients the opportunity to ask more questions.
Project Boost is furthermore committed to improving transitions of care in a cost-efficient manner.
Project Boost provides, if you will, a minimum foundation of hospital care for patients as they're transitioning. And that's one of its goals, is to make sure that all patients leave the hospital understanding what happened, understanding the tests that they had and what the results were, understanding the treatment, and then understanding what they're supposed to do when they go home. And that is our goal for Project Boost.
The value of Project Boost is evidenced by a rapidly increasing number of organizations that are member sites. One is 481-bed Piedmont Hospital in Atlanta, Georgia. Piedmont's leadership has made improving transitions of care a priority.
In order to really claim success, the patient has to have a successful transition back into the community and be able to remain in the ambulatory arena. The other reason that we focused on our transitions of care is we know that many processes in the hospital have been in existence for many years, and continuing to do the way we've done things because that's the way we've always done them really is not going to help us succeed in the future. Piedmont chose to get involved with Project Boost because we were in the midst of re-engineering our discharge process as part of a greater effort to really take a long, hard look at the experience of our patients in the hospital from door to discharge. So we had developed geographic units for our hospitalist physicians, and we were looking for tools to assist us in identifying patients that may be at risk for failed discharge and to help us manage a better discharge process.
We were primarily and philosophically an acute care facility, and that's where our concentration was. When we were chosen to be one of the hospitals to pilot the Boost initiative, it was a great shift in our thinking from acute care to discharge planning and safety in transitions.
As with any major change, however, challenges needed to be overcome.
When you have the old process, which is outdated and cumbersome, and you're transitioning to a new process, which is hopefully more efficient, in that middle zone, there is more work and it is more difficult. And it's essential for leadership to be supportive of the workers as they undergo this change so that we can get over the hump.
Initially, Boost was designed for our elder population, and that was the initial focus. We felt so strongly about what Boost had to offer here that we now boost everybody. Boost afforded us interdisciplinary responsibility, affording the right person for the right job, making sure that discharge did start on admission, streamlining the length of stay process, streamlining the acute side of the patient's care so that the outside patient care could be more timely and efficiently managed as well. It helped us execute more safe discharge plans.
Another initiative that is positively impacting transitions of care is Project RED for Re-Engineered Discharge. Led by a research group at Boston University Medical Center, Project RED is developing and testing strategies to improve care transitions cost-effectively while also promoting patient safety and reducing rehospitalization rates. Project RED's primary investigator is Dr. Brian Jack.
Project RED is a list of 11 components that we think is important for every patient to receive before they go home from the hospital. It's similar to the takeoff checklist that the pilot and the co-pilot go through before they take off. The first is that we educate patients about their diagnosis. There was a study that came out when we were designing the re-engineered discharge that showed that about half the patients from a Mayo Clinic study who had been discharged from the hospital weren't sure of what their diagnosis was. And we said that, gee, people really ought to know why they're in the hospital, and this ought to be part of the re-engineered discharge. A second very important component is that people receive an appointment for follow-up. It's remarkable how often people are discharged from the hospital without a follow-up appointment being made for them.
The third aspect of Project RED is to identify tests that were done in the hospital, but for which the results are not yet back. A discussion then occurs with the patient about who will be responsible for following up on those results. Similarly, a discussion takes place with patients about RED's fourth component, which involves the organization of post-discharge services. Patients are made aware of the importance of these services and how to receive them.
Another very important part of the re-engineered discharge is organizing the medications, doing medication reconciliation, and teaching the patient about what medications it is that they're supposed to take when they go home.
And it's also key to reconcile the patient's discharge plan with national guidelines for care and treatment.
We know that for certain conditions there are recommendations that are often not followed by clinicians, and that there are data for people who come back to the emergency room saying, what % of patients are not taking the medications according to the national guidelines that potentially could keep them out of the hospital. Well, why not do that at the time of discharge? A very important part of the re-engineered discharge, too, is being sure that the patient knows what to do if a problem arises. They need to have, before they go home, a phone number or a clinic or a plan.
The eighth essential ingredient for Project RED is transmitting information about the patient's hospitalization to the patient's source of care in the community upon discharge. Currently, in many hospitals, the discharge summary is generated 30 days after discharge. But unfortunately, the more time that elapses between discharge and dictation of the discharge summary, the less trustworthy this summary becomes.
Another key piece of the re-engineered discharge is assessing the degree of understanding that the patient has of the plan, so that we do teach back in terms of we teach the after-hospital care plan to the patient and then ask them some key questions to test their competency, their understanding of what it is they're supposed to do when they go home. One of the most important components of the re-engineered discharge is the after-hospital care plan. And this is a document that sort of operationalizes all the key elements of the re-engineered discharge in one place.
Finally, with Project RED, a follow-up telephone call is made to the patient 2 to 3 days after discharge. But this is not a simple social call. Rather, it reinforces the discharge plan and enables any problem solving that needs to occur.
Yeah, people ask me about who should receive Project RED. And I think the answer is that I think everybody should, because it's simple and that even people who are at low risk for coming back to the hospital benefit from having an after-hospital care plan that clearly articulates what it is they're supposed to do when they go home.
The last initiative we'll cover that's helping to improve transitions of care is the Care Transitions Intervention, developed by Dr. Eric Coleman, professor of medicine at the University of Colorado, Denver.
When we embarked on the journey of creating the Care Transitions Intervention, the smartest thing that we did was to take the time to listen to what patients and families had to teach us about their care experiences and how they could be improved. So rather than simply saying that this is a patient-centered intervention, we actually wanted to be true to this.
In response, the Care Transitions Intervention develops in patients the key self-management skills they'll need to assert a more active role in their care. A good deal of this preparation is provided by a transitions coach.
Bless our hearts, but almost every healthcare professional believes that they're already coaching patients. But I would draw a clear distinction between education, something that's also very important, but distinct from coaching. In our care transition and intervention, coaching involves skill transfer. Skill transfer in turn involves role play, practice, rehearsal, simulation, actually having the patient try this out themselves.
Dr. Coleman asserts that there are 4 gaps that represent areas that patients have identified as those that they need the most support with in managing their own care, calling them the 4 pillars. They are patient self-management of medications, the importance of a patient-centered health record, timely primary care and specialty care follow-up, and knowledge of and responses to red flags that indicate a worsening patient condition. The Care Transitions Intervention is designed to close each of these gaps. The process starts with engaging patients by asking them to set goals for themselves.
By asking patients to identify their goals in their own words, we're given a tremendous opportunity to help meet them at their level. I can assure you that in doing this with thousands of patients, none of them have identified reducing their hemoglobin A1C by 2 points as their goal. That's our goal. That's an example of a provider goal. Patients' goals are often more likely to relate to function and to their overall quality of life.
In rigorous trials, the Care Transitions Intervention has not only led to reductions in 30-day readmission rates, but also as far out as they were able to measure, which was 6 months later. Overall reductions in readmissions have been on the order of 50%.
The Care Transitions Intervention is unique in that it's a self-management model. Our transition coaches do not come in and fix patients' problems for them, but rather they coach them through a series of common transition-related scenarios to help them gain the confidence to ensure that they're going to be able to meet their needs across the different care settings. The analogy of the difference between giving an individual a fish and teaching them the fish certainly applies here. Our transition coaches are largely teaching these individuals to fish.
One organization that uses this process is Health East Care System, based in St. Paul, Minnesota. Health East, in 2006, began a quality initiative they call their Care Navigation Strategy. It was this effort that led to their focus on transitions of care.
Our initial commitment was to go across our entire organization and get the right people in the room. And it's the people who were at the bedside or have physicians who are very interested in this. And then we used a very specific approach so that we could strategize and identify priorities. Out of that came the real need and focus for us to look at care transitions and ensure that we had the best process in place to really support that.
A closer look at transitions of care confirmed that because the one certain constant in the care continuum is the patient, it was critical to empower that patient. This was where the transition coach could really help.
The transition coach is focused on understanding what the patient's follow-up needs are and then making sure that that actually happens. So whether the patient is still in the hospital or even after the patient has been discharged, they make sure that they understand that patient's unique discharge plans, needs, medications, follow-ups, and then they're in contact with the patient.
Not all patients require a transition coach, but the organization ensures their patients are aware of the program.
How is their home set up? What is their support system? What are their needs and desires? And through that assessment and that conversation, we can help. And often the patient doesn't know that there is such a service available, and we can tell them about that service, and many patients are very, very interested in that.
Through patient feedback, one thing that's been discovered is the importance of patients maintaining their own record of their health.
The biggest thing that we have for the patients is our personal health record. It's a booklet that we have that we give to each patient. It's just maybe 10 pages long. It's where they can keep track of their medical course at this time. It has a place for hospital dates, what was done in the hospital, if they had surgery, exactly what kind of surgery was done. And having it written down, having an actual one place to write things in, gives them control of what they want to know and what they want to tell other people.
The transition coach has consistently been around 11 to 12% readmission rate, which, considering we're talking about the most at-risk population, we consider that a phenomenal readmission rate.
The organizational benefit to an effective transition care plan and process really is that we become known for good outcomes. And if we're looking at things like whether or not the patient left our hospital and had the right follow-up care and had a good outcome, that's ultimately what we want to do. That's our mission, is to improve the health of the community we serve.
In this program, we have profiled several initiatives that represent new approaches to care transitions. You may want to consider the following questions as a starting point for furthering your knowledge and understanding. How would you survey your patients about their goals for discharge? At what point during the hospital stay would you introduce this topic? How might you better incorporate the patient's voice into discharge planning? Do the materials that you provide to patients at discharge have the characteristics described earlier in this program that support optimal patient understanding? What type of performance improvement methodology is used at your organization? And how does this methodology support analysis of your current transitions of care process and your plans for improvement? Given the initiatives that we've seen in this program, along with others that are now starting to make a difference, it's very encouraging to see that improvements to transitions of care are becoming a greater priority for healthcare organizations. And your patients are the real beneficiaries of these improvements as they make their way back home.